let's get started. I'm Megan Haupt. I'm Chief of Staff with the National Association of State Mental Health Program Directors. I'm really excited to be hosting today. We are going to have a featured presentation on dispatching emergency responders, and it's Jason Friesen is going to be doing that. We're really excited about this. It's just so important. Next slide, please. Great, and we want to highlight that we have 71 national organizations part of this learning community, and that there have been kind of 5 top episodes that are highlighted here that have been viewed. The actual participation on the Zoom was high, but then the YouTube participation has been high. And so the highest one was when 988 went live. That took place, that episode took place July 13th in 2022. And the next highest one is last week's on youth. So we're really excited about that. And you'll see the YouTube viewing is very high from last week, and it's almost edging to that going live one. So we encourage you to share the links, share the information that's on the Crisis Talk website, and we'll get to that. If your organization, by the way, is not added here or you don't see it, please let Karen Jones know, and we will be sure to add you. We also, you can see there are different countries as well, so we're very excited about that. All right, next slide, please. Great. If you had the Crisis Jam on your calendar and it's no longer there, you can click there to download the calendar invite. You can also get the calendar invite from the Crisis Talk website as well. And here is that Crisis Talk website. So you'll see there's the Zoom link, and you'll see the videos and the materials. When you sign up for that weekly reminder and that newsletter there, that's how you're added to this learning community. And you would have seen in the previous slide, you don't have to go back there, but we have over 3,000 people part of this learning community. So sign up there if you're not already there. And again, just more materials and videos. And now we are going to talk about, we are on the 109th episode of the Crisis Jam, and about the first 7 were kind of more informal. But this is, what do 100 Crisis Jam episodes look like? Now, this is amazing. I thought that when I saw this slide that it kind of looked like a wonderful way to do a jigsaw puzzle, you know how they have kind of, but what this is it's organized by topic, actually. And so each one of those little icons is the featured presentation from each of these 100 episodes. And so we're really excited about all of the topics and pipelines that we have with these episodes. And if you go to the next slide, it goes, it'll discuss, should soon show how the topics are organized. Great. And so there's system design and peer support and Medicaid payers. You'll see mobile crisis, receiving facilities, child and youth. You'll see all of those. We've had deaf and hard of hearing, 911 and EMS. And if you go to the next click, you'll see how many episodes are on each of these topics. And so what we want to do, look at that, 8 on peer support, 11 on system design, 7 on 911 and EMS. And then some of these even have some overlap, where some rural issues go across. For example, in technology, there's ED boarding, but these are amazing in terms of being able to really note the history. Wendy Tygreen notes that, an emphasis on peer support as well. So what we want to find out from you is, here are the topics, here's how many times we've addressed them in different ways. What is of interest to you to see in terms of topics for the future? what would you like to see more of? Maybe that's already been done or touched on. So if you could just put in the chat, please feel free to blow up the chat on this, on what you want to see more of. And we're going to track that and make some planning around that. And I do want to note, there's one been on IDD, the history of 988, violence and threats. I mean, just really take a look at that. These small ones, advocacy, and we've had one on COVID-19. And there was even a small series kind of informally on some COVID-19 as well. So fantastic. If just start putting your ideas in there, we'll keep tracking them. Appreciate Dawn Peel saying deaf and hard of hearing, language and culture. That's a great idea. We see violence and threats, more on that. Crisis prevention, yes. Great. Even what is beyond crisis, special populations, receiving facilities, alternatives, and rural communities, LGBTQ+, culturally appropriate responses, more on IDD. Yes, that's really domestic violence, I see, peer support, early intervention, way to blow it up. Hey, psychotic disorder crisis, follow-up, nice. Why video relay is needed for 988. And EBP training options for crisis intervention personnel. And on the video relay piece, I know in the works, they're looking to establish a 988 national center where there would be actually trained crisis counselors that would do video relay for that. And great, older populations. So wonderful ideas, and just keep putting them in there. That's fantastic. And let's go to the next slide. Wonderful. Just want to highlight that a crisis call center was highlighted in Hyattsville, Maryland, and mainly about that the volume of calls is noted, cries for help, 4 into 988 mental health suicide line. And that's just highlighting that piece. And thrilled that Richard McKeon from SAMHSA got this photograph on, walking down the street, sees this advertisement on the side of a bus, took a picture for us. Being strong doesn't mean you have to do it alone. Call us, we can help, 988, call or text. And it's fantastic. That's in everyday mainstream. And we want to keep doing that. And this is the latest crisis news. This was an article from December 13th. And it partly had to do, we wanted to put this into last week's episode as well, but this is about disruptive or depressed psychiatrists reach out to teens of color. And this was an article in the New York Times, really talking about how crisis for Black teens and Black youth. And the quote of the week, this comes from Haley Winterberg, who spoke last week. And she was a youth leader about 9 or 10 years ago. She's still a leader, but she was a youth leader 9 or 10 years ago. She says, listen to youth and bring them to the table. Let them make a difference. You'd be surprised. Great quote. And Haley just has made a huge difference in the world. Great, we're now gonna move to our featured presentation, Deploying Emergency Responders. This is Jason Friesen, and who is the founder of Trek Medics International. And I'm gonna turn this over to Jason. Thank you so much for being with us today.
Thank you, Megan, and thanks to the whole team for having me. It's a real pleasure to be here. So as Megan mentioned, my name is Jason Friesen. I'm a former paramedic and the founder of Trek Medics International. We are a nonprofit technology organization, and we build a crisis response platform called Beacon, designed specifically for response organizations to allow them to alert, coordinate, and track responders on any mobile phone with or without internet. And I'm going to get more into that about what our Beacon platform does and how different mobile crisis response teams are using it. But first, I'd like to give a little context about how this fits in to the 911 promise. And if you could go to the next slide, please. So we're all aware of the progress that's being made, the wonderful progress that's being made nationally with 988. And as everyone starts to come online and is accomplishing the first horizon of someone to talk to, little by little, jurisdictions are changing their focus to start looking at the second horizon, which is someone to respond. And so this is kind of the bread and butter for 911, right? Sending the right responder to the right location at the right time. But for 988 call centers and affiliated crisis hotlines, normally, and this is a bit of a generalization, but normally they're accustomed to doing over-the-phone consultation. However, with capacity and funding and leadership, they're going to be starting to send responders to do in-person interventions. And so this is an area that we have a lot of experience in, right? How do you build a crisis response team or system from scratch? And we kind of came about it in a roundabout way. And as you'll see in the next slide, and I'd like to just give you a little more context about how we got where we are. So Trek Medics was by and large forged or born out of the Haiti earthquake in January of 2010. Myself and some colleagues were sent on some disaster response teams to Haiti in the immediate aftermath. And Haiti had a very difficult situation before the earthquake, but earthquake made it exceptionally difficult. The minimal infrastructure that was in place was all but destroyed. They didn't have a formal 911 system to speak of, though they did have various, ambulance services, private or even community-based. But one of the things that we noticed while there was, despite the fact that Haiti had minimal healthcare and emergency response infrastructure in place, if you went to the hospitals were packed, and they were packed full of people with very acute conditions. And so that kind of raised the question, how is it that if you don't have the infrastructure for a formal emergency response system, but the hospitals are packed with people that would normally be transported by an emergency response system, how did that happen? And the answer was, it was informal networks that were banding together and making sure that the right responder got to the right location as quickly as they could. And there were some basic components to this that we noticed, that there were highly motivated community members who had some form of transportation. As you can see in that middle picture, that's what they call a top, which is basically a pickup truck that's been converted into public transport. They all had mobile phones, and mobile connectivity was everywhere. And the healthcare facilities were accessible. The services they offered obviously varied, but these kind of four components all in their own way brought together an informal emergency response network. So after we left Haiti, we were kind of talking, how is it that you could bring some coordination to this informal response system, right? How could you bring some formality to it, some predictability to it, some reliability? And we decided, in our mind, the big problem was communications. That in the United States, most 911 call centers are using what's called a CAD, a computer-aided dispatch platform. And it's how they alert, coordinate, and track responders. The problem is with the legacy CADs, as we call them, is that they're very expensive and they're not necessarily appropriate for low and middle income countries, right? They were by and large built for the United States. So they're too expensive for low and middle income countries. And they're also not appropriate, right? It's just, they're working on different infrastructure bases. So we said, this is where we should focus our energies, is we should build a lightweight CAD that can be used by any emergency response group with whatever mobile phones they have in their pocket. And as you'll see on the next slide, this turned out to be Beacon. And what we did was we identified, if I was working on the ambulance, you can go today and you can look at an ambulance or any fire engine or any police cruiser, and you'll see in the middle, usually it's, sometimes it's a tough book, but oftentimes it's like a console that's bolted into the middle of the ambulance, and it's got a touch screen. And that touch screen is asking the same repetitive questions over and over. And this is what we call the universal emergency response workflow. So it all comes in, people call 911, a dispatcher answers the phone, they triage the caller, and then when they decide to dispatch, they go through the same steps every single time. And those steps below are in blue. And this is what the mobile data terminal was asking us on that touch screen was, are you on your way? Are you on scene? Do you need additional resources? Are you transporting? Are you at your transport destination? And it didn't matter what the emergency was, right? It didn't matter if it was a woman in labor or a mental health crisis or a 3-car pileup. It was the same steps over and over and over again. And the reason for that is because emergency response is actually very predictable. What changes is what happens when you get on scene. And that is totally dependent upon the training and the resources that the responders have. So we said, let's take this emergency response workflow, and instead of relying on these very expensive, hardware and computers and tough books and all this stuff that is used in 911, let's make it so it's accessible on any mobile phone. And as you'll see in the next slide, this is where Beacon came from. And so now today, Beacon is a pretty sophisticated, I would say, arguably a very sophisticated CAD, but it's a lightweight computer-aided dispatch system. And it's used for exactly that, to alert, coordinate, and track responders on any mobile phone. And when we built it, we knew that we were going to be building it for people in very challenging environments with minimal infrastructure, with questionable connectivity, or I should say inconsistent connectivity. And so we knew we were going to see a lot of different things working in low and middle income countries. So we made it very flexible. So one, anybody can set it up. They don't need any help from us. They can go to the website and create an account. Two, it's going to track responders in a number of different ways. If they have smartphones, GPS. If they have only SMS, then we can track them through updates and confirmations. We've also set it up so you can integrate it with your 911 CAD, or you can use it as a standalone CAD. And of course, we've included all of the reports that are needed to prove that you're doing what you say what you're doing. So we started focused on low and middle income countries, but as our software got more and more sophisticated, we began to be approached by what we would call alternative response groups in the United States. Mental health crisis response teams, domestic violence response, opioid overdoses, violence intervention, all of these groups, and particularly in the aftermath of the murder of George Floyd, we started getting a lot of calls from community groups that were saying, we need a simple way to alert, coordinate, and track our responders. 911 won't plug us in, or it's too complicated, or we don't have the money for that. We need something lightweight. We need something affordable. Will Beacon work? And at first we were intrigued by it, but we were like, well, let's see, what you're doing is similar to what a 911 responder is doing, but this is an alternative response group, so maybe you do things a little different. So we started working with them little by little, and it didn't take long to see that it was actually working very well for them. And if you go to the next slide, I'm going to show you 3 examples of groups that are using our software today. And 2 of them are actually going to join us for the roundtable after. The first one is Telecare in San Diego, and they're using Beacon for their mobile crisis response teams. And as you can see, access happens in different ways. Either someone calls the San Diego crisis hotline directly, or they call 911. But either way, when deemed appropriate, they are transferred to the Telecare virtual call center, where the dispatcher continues the interrogation of the caller, or the inquiry of the caller. And then they decide if response is necessary, they use our software to dispatch their mobile crisis response teams, who then respond, get on scene, determine if additional resources are needed, perform an intervention, whatever that may be, counseling, referral, additional social support, and then they ultimately reach a resolution, which may include, as we would call an EMS, treat and release. All's good, it's taken care of for now, or they can refer them to other facilities or caretakers for additional services. And as you can see, it varies month to month, but generally speaking, their response times are below 25 minutes and oftentimes even more farther below that. The next slide is going to talk about another group called Safe Nest in Las Vegas. And this is a fascinating, an absolutely pioneering program that works in tandem with the Las Vegas Metro Police Department. It's not a co-response program, but they work in tandem so that when a victim of domestic violence has been identified and they need additional support services or social services, whatever it may be, that Las Vegas PD will call up SafeNest, or the person will call SafeNest directly. The dispatcher will take the information in, and then they'll send out the alert to their responders. And they have a pool of responders, whereas telecare is kind of doing your traditional, they pick a team, and that's the team that's going to go. SafeNest uses it a little different in that they'll have a pool of advocates, and they'll send out the alert to them to see who can get there first. And so it's kind of more like a crowdsourcing option, right? What we call broadcast alerts. And so once that advocate has been identified, they confirm through the app that they're en route, that they're on scene, if they need additional help, or when the call is over. And in this case, the intervention can be giving them additional social services, access to support, or even getting them to a safe house. So that's another awesome program that's using our software and just doing fantastic stuff. And both of these programs are doing hundreds of calls a month and have been growing. So really proving that once you get it started, they can keep moving. The other program is in Hartford, Connecticut. This one is for opioid overdoses. Sometimes people report an opioid overdose directly to them. Other times they listen to the 911 scanners and wait to hear when an overdose has been reported to 911. And then they send out alerts to their street outreach workers who are equipped with a naloxone and can get on scene to reverse the overdose. And their response times last month was 4 minutes and 10 seconds. So they're really fast. And for an overdose, obviously you have to be. 50% of the time they get there before police, fire, EMS, 50% of the time they get there after. But in both cases, they're able to provide access to referral and wraparound services that police, fire, and EMS can't. So those are just a couple of the many programs that are using our software. And I think they're really emblematic of the awesome work that can be done when you're coordinating and doing it in a predictable way. The next slide, please. So as you are looking to start implementing mobile crisis response teams, and you're considering the technology needs, I would recommend these 6 questions or 6 areas that you can go through to assess what needs you have. And my contact information is next, and I'd be happy to talk, offline with anybody who wants to about this. But basically, understanding the scope, what types of crises, the range of crises you're going to be responding to, how are people going to access your services, how are you going to handle calls when they come in, what are the questions you're going to be asking, what are the protocols you'll be using to triage, the response part, right? These are the things you need to take care of no matter what the response is are they en route, are they on scene? Do they need additional resources? Are they transporting? Are they finished? Also documenting your intervention, preferably through technology, so it's easy to hand off to people who are, monitoring what you're doing. And then also the resolution. How do you know when the final objective is met? How do you know when you've had a successful response? So my next slide is just more contact information. If you'd like to talk more, please feel to reach out to me at any time. There's my my phone or my email. If you think Beacon might be useful to you, by all means, you can go to our website at trekmedics.org/beacon. You can create on your own an account and get up and started and running with it. We have seen people get up and running with it and never talk to us and hit the races running there. So it's definitely available to you. And also, just as another thing, if anyone is involved in active crisis response programs and you'd like to share your story, we've got a new podcast we've launched called the Crisis Response Podcast, and we'd love to have you just sharing what your work is, how you got it started, where it's headed, and what you've accomplished. So thank you very much for the time, and I'll pass it on now in case there are any questions or to the roundtable. But thank you very much.
Great, Jason. Thank you very much. What an amazing background and story and how that works. We did just have a couple questions in the chat box I just want to take a look at. First of all, Rob Clark makes the comment, this is the type of technology that fits the ecosystem. Bravo, Beacon. And Suzanne, I think it's Rabid, or forgive me if I'm not pronouncing your name right, but they're asking, how could the system integrate with what Vibrant is putting together with Salesforce? Do you have any ideas on that?
I would have to learn more about that. But we do lots of integrations, and I'd be happy to explore that and see what's going on. I'm not entirely sure what that is, what's being done, but I'd love to learn more and talk about that.
Great, great. And Suzanne also asks, does the system also have a workforce management tool for predicting future needs and for scheduling of mobile staff?
Yes, we do. And in fact, we've gotten a lot of support from technology companies like Cisco, PagerDuty, Twilio, even Google at the beginning. And we're working now with Cisco on exactly this type of functionality to be able to be more predictive and have those predictive analytics. But that's absolutely stuff we're involved in and are continuing to scale up.
Great, great. And it looks like some people want some access to the podcast that you referred to. So if you have a link you could put in the chat, that would be great. I do see your question, Jenny Harville. If communities have access to 911 CAD, would a lightweight hack like Beacon be needed? If so, why?
That's a great question. And this is what a lot of people are learning when they go and approach 911. The 911 CADs are traditionally set up for fire, police, EMS, and they're not altogether ready for alternative response groups. And there's also oftentimes concerns about plugging in alternative response groups into the police, fire, EMS CAD. So we've seen a lot of times that we have an integration where it can act as an extension of the 911 CAD and share information both ways. But it really depends. I mean, there was an episode, a Crisis Jam earlier where they were talking about, if you've seen one 911 call center, you've seen one 911 call center. And so they're all using different things. I mean, there are some legacy providers that take up a big market share, but they all customize what they're doing. And they're all focused on police, fire, EMS. So they're not typically ready. It depends, again, on volume. It's a case-by-case basis, but oftentimes we find that our software is successful as an extension of the 911 CAD.
Great. Great, great, great. And let's go to Liz Ortenberger, who is CEO of SafeNest, who you had mentioned in your presentation. Liz, go ahead, please.
Hi, thanks. And thanks, Jason, for the great overview. So I will just tell you how we use the program. We deploy about 10,000 responses in partnership with our Metro Police. They are scenes within Las Vegas in which an arrest has been made or there's a probable cause for an arrest, but the perpetrator of the domestic violence has fled. And we do this because there is one stat, a series of stats that made this very clear for us. Only 4% of women will reach out to an agency like SafeNest, and I would extend that to say probably 988 as well, within the 12 months before they're murdered. But 86% will have an intersection with police. So if we are not intersecting with our police in the space of highly lethal domestic violence, we are not doing our mission mandate. That's just the bottom line for how we work the program. And that was the bottom line for funding as well. So it's really quite simple. Police respond to a scene. They make the scene safe. As soon as they log it as a domestic violence, 911 dispatch calls my dispatch. My dispatch puts the information into the app. Whoever is available and closest responds. They by pressing a button in the app, they respond. They hit another button when they're on scene, and then they hit another button when they leave the scene. And then as they drive away, they call my hotline, and that information gets inputted into our client software. The reporting inside Beacon is incredibly, there's a lot of data that you can pull. In fact, I just pulled a report this morning for our communication company because we're having a problem with the time we're putting information in the app to when it's actually populating. It has nothing to do with Beacon. It has everything to do with a bandwidth issue I have in my building. Super helpful. Also helpful is when I meet with the chief of police and I show him that we went out on 10,000 calls. We brought the homicide rate down by 7 to 15 survivors, depending on which data analytics set we're looking at. For our police force, every homicide costs $8 million. So there's a savings of $80 million of impact that we've made in a year. And I can give also the time that one of his officers had to stay on scene, and he can do the math against how long his officers have to stay on scene against $80 million. And we can very quickly see the ROI. So there is just a ton of reasons why this speaks to folks who have to make tough fiscal decisions, but it speaks to us doing this direct service work, like many of you, that we've got to be in the places that survivors need us. And that's how we utilize the software.
Liz, that is amazing. And what amazing $80 million. And then there's the life that's saved, right? I mean, it's just phenomenal. Thank you very much. Very enlightening. And Tim Graves, Director of Special Projects for Telecare, which was also mentioned in the presentation. Tim, are you there?
I am. Good morning.
Wonderful. If you could just, what is any comments you have, any reactions?
Yeah, absolutely. You know, I work for Telecare Corporation. We provide behavioral health services for folks with severe mental illness across 7 states. Last year, we served about 35,000 clients. And we really run all spectrums of care for the SMI population, from crisis stabilization units all the way to community-based care. So we operate a number of different programs in 32 different counties. And about 18 months ago, we were awarded a contract by San Diego County to provide mobile crisis response in the entire county, which is a very large area. I have a background as an EMS professional and a technologist, and we really had 90 days to stand up a mobile crisis response team. In total, we have about 90 employees at our San Diego MCRT team, and we run 24-hour crisis mobile crisis response. When we were first looking at the project, we really used SAMHSA's mobile crisis intervention framework for the basis of our program, and it was really helpful in getting off on the right foot. We also partnered very closely with the local LIMSA and EMS agencies and police as well, public safety, to really establish some partnerships to make sure that we were part of the coordinated system of care. That said, when we were designing our mobile crisis response team, we did something that some counties are taking a different approach on. And we really stayed focused on the most important thing in mobile crisis response, which is getting a trained clinician to a client so that they can provide interventions. A lot of counties that we've seen are really focusing on tight integration at the system level with technology. And that dramatically increases the complexity of standing up these programs. We were able to start providing services within 90 days. And the partnerships were there. So it was a coordinated effort, but we really needed a CAD system that enabled us to be successful. And that's when I reached out to Jason and Trekmedics International. And within about 2 weeks, we had stood up a CAD system. We had implemented our crisis workflow. We had a screening workflow set up for our clinicians in our virtual call center. And we're able to start providing services very early. To date, we have, on any given day, we run about 8 to 10 mobile crisis teams. Our crisis teams are comprised of a peer support specialist, a licensed clinician, and an unlicensed case manager. And those 3 work very similar to what you might find with an ambulance crew or a fire engine company. You know, they all bring different competencies to the intervention. And, in San Diego, our population, there is a lot of homeless and unhoused. And, one of the things we do, in addition to just crisis intervention services, is we provide really transitional care and care coordination. And that was another really important aspect of our program. So not only are we responding to crises, but we're also following up with folks that we might have responded to earlier and making sure that they're supported beyond the crisis so that they get to those other levels of care, and that there's good continuity of care.
And that is wonderful in terms of the follow-up. That is so important, so that people don't keep cycling into that system. And we know that follow-up is so important to keep people out of crisis as well. So fantastic work. You'll see some questions in the chat box, Tim, particularly from San Diego local crisis text line, and perhaps you can put that answer in the chat box for everyone to see.
Yeah, absolutely.
Okay.
Or I can answer it in person here.
I'm so sorry, we have to move on, but I want to thank Jason, Liz, and you, Tim. Thank you so much for all the work that you're doing. I do just want to remind everybody about the SAMHSA store. It has printable products. So the link is in that bottom left part of the slide here. And you can order up to, what we found out, about 326 items for free until you start paying. And there are stickers and pads, wallet cards, magnets, posters, etc. And there's also 6 Spanish options for that. I want to remind you about the t-shirt. Now, the t-shirt, if you are on the trivia hot seat, which Jordan Pantalone will be in just a moment, Jordan will be allowed to pick from 4 different logos and 5 different quotes. And there's English and Spanish. There's short sleeve and long sleeve. There are hats. And I hear that there are mugs coming about. So very exciting. So let's go to Jordan. Let's go to Sassy Jordan. How you doing, Jordan?
I'm good, Megan. How are you doing today?
Doing great. Jordan, I'm going to read you the question and just remind you that you can trust the audience if you want, or you can call a friend. But here we go. Psychiatrists reach out to teens of color. In December, the New York Times highlighted an Atlanta team of Black mental health experts led by Dr. Sarah Vinson, bringing care to low-income children and teens of color. The New York Times article begins with the impact of workforce shortages and low-income communities of color. The crux of the story is the fork in the road caused by the lack of, and I want to remind you that this is from the New York Times article. So, and Jordan, I want to let everybody know, Jordan is from Vibrant Emotional Health, and he just does great work with the states. So Jordan, what do you think? And everybody can put their answer in the in that poll as well.
Yeah, this is a tough one because I really do feel like it could actually be any of these. I have maybe a gut reaction of B, but I would like to see what the audience has to say. I know I said I wanted to try and do this on my own earlier, but judging by the difficulty of this question, I would love to see what the audience has to say. A lot of smart people on here.
All right. 81% say timely access to care. And then looks like there's a little bit of a mix between accurate diagnosis and success in school. Just a reminder, it's from the New York Times article, because I think you are accurate that maybe all of these apply in some way. So Jordan, what do you think?
Yeah, I'm going to go ahead and lock in B there. Just trust the audience here.
Okay. Sure you don't want to phone a friend?
Yes, I'm sure.
Okay, great. All right. Well, let's go with
there you go.
Accurate diagnosis. Now, that in part because of the workforce shortage, they're finding that they needed better trained folks to really be able to nail down what that diagnosis was. And some of the diagnoses were harsher because of some of that poor, I don't want to call it poor training, but not quite trained fully and have enough people and clinicians to really nail it down. So good going, Jordan. It was a tough one. All of those answers could have applied in some way. So good work. All right. And you get a t-shirt. So, and also David Covington points out, bias is also likely a dominant factor. All right. Let's move to the next slide. And we're going to go to the Crisis Talk article. And Stephanie Hepburn is on along with Arlene Stevenson. And Arlene is with NASHBID and was also former acting Secretary of Health and Mental Hygiene and Deputy Secretary for Public Health Services in Maryland. So we're delighted to have you both on, and I love working with both of you. So Stephanie, go for it.
Thanks, Megan. So Arlene, can you share with us, in the article, you talked about disparities in insurance benefit parity, but you also talked about how states are using 988 to try to remedy that in building out parity, specifically insurance parity. Can you talk a little bit about what some states are doing?
Absolutely. First of all, I think it's important when you think about this to realize that the federal parity laws create a national floor for protection. It's not a ceiling. So the states are free to create their own stricter laws or to, add to the federal laws. So what are they doing? Well, the first thing they should be doing is looking at the federal laws. The federal laws are very comprehensive. Do they need to more support for that? Then they should be looking at their own statutes to see if they have gaps. Could they or should they be strengthened? They may not need to, or they may not need to go with legislation. It might be a change they could make without legislation. The actions that they're taking, I think first is they're really talking to people. They're surveying their stakeholders, trying to figure out what problems they're seeing out there. They're also looking at claims. They're looking at claims denials. They're looking at the services that are an issue. And we know from data that there are big problems in inpatient and partial hospitalization and outpatient and in medication-assisted treatment. I think that the things they can find the most easily, I think, are those by looking at patterns within the data. When you see frequency, it often indicates policy issues. So that's a good place to start. They're also developing their own parity compliance processes. Those are to kind of complement those that are being used by the federal enforcers, the Department of Labor and HHS. So they may need the statutory authority to collect information for analysis. They may not have the right to ask for data from the insurers and expect to get it. So they may need the authority to do that. The states are also, state agencies are partnering with each other to close gaps, to do enforcement, to do consumer education. It's usually the insurance commissioner, the state behavioral health authority, the AG, and the Medicaid program that usually get together to work on this issue.
So partnership.
Yep, partnership. They're stopping, they're looking to limit gaps, stop gaps in reimbursement, such as in and out of network services. They're paying a lot more attention to coding their bills to make sure that they get reimbursed. They're revising definitions to make sure that their statute actually jives with the definitions that insurers are using. So that's not a hole. And they're also requiring notifications of individuals who receive a denial so that they know what their rights are and how to appeal it. So, states are interested in this. Again, primarily in the crisis services realm, because it's a sustainable funding source. So
Yes.
that way they want to use that to support their systems. I would like to see states begin to involve employers more. Employers are spending about 7% of their budgets on average on employees' premiums. They have a lot of power over insurers. So I think that would be something that would be hopefully in the future.
Thank you, Arlene. And I love what you started with, that the federal parity law is the floor, not the ceiling. Thank you so much for hopping on with me.
Thank you. Thank you for bringing this to the front.
Thanks.
Great. Thank you. And I want to turn it over to Pooja Mehta, who to talk about the promise of 988. And Pooja, are you on?
Yep, I'm here.
Fantastic. If you could just say a little bit about yourself and then say how we will know when we have arrived with 988.
Yeah, hi everyone. Thank you all for allowing me to take a few minutes of your time and share my thoughts. A little bit about me. I am currently working as the senior policy advisor at Inseparable, and have been involved in mental health advocacy in a variety of capacities for about the last 10 years. And, to give you some context about what brings me here, I want to tell you about November 9th, 2015, which was the day of my last suicide attempt. This was the last time the voices in my head got so loud that I was ready to do anything to make them stop. And that was the last time I sat in a police car and was escorted to the emergency department, the last time I laid in a room in a paper gown and counted all the tiles on the ceiling while waiting to be seen by my doctor. It was one of the worst nights of my life. I didn't know if my parents knew where I was. I had no way of contacting them. A handful of my dorm mates in college had seen me get walked to the cop car, and I was wondering what they were thinking about me. And yet I look back on this experience with gratitude, because when the police came to my apartment and found me screaming and holding a kitchen knife, I rode to the emergency room in a cop car, but in the front of the car without being handcuffed, tased, or shot. When I sat in the room running about things to worry about, money wasn't on that list because I had incredible insurance through my parents. Shout out to the ACA. And when I went to sleep that night, it was in my own bed because my parents were close enough that they were waiting in the waiting room when I got discharged, and I had a care team established in the area. My experience was really traumatizing, but it was a product of extreme privilege. And I think we'll have arrived when it wasn't. When my experience isn't contingent on it, like isn't the outcome at all, much less an outcome that is informed by access to money, access to resources, access to a supportive community. In the 7 years since that day, crisis response, mental health care, and the conversation around mental health has changed and improved exponentially. But somewhere in this country, today could be someone's November 9th, and no one should go through that. And so I'm really glad that I'm here, and I'm really glad that we're all here, because this is the work that we do, to make stories like mine just what they're meant to be, just a story, a relic of a past that pales in the reality of the future that we're all building together. So thank you.
Pooja, that is incredibly moving, and what an incredible insight also on the access that you had, and the hope that everybody gets that level and more, despite the level of money they have or the community support they have. So thank you very, very much for sharing your story. We really appreciate it.
Thank you for having me.
Absolutely. And we're now going to move to Richard McKeon from SAMHSA to provide an update. Thank you, Richard, for being on.
Thank you. Thank you very much, Megan. And I wanted to echo Kate Gladys's thanks for bringing attention to the resources available on SAMHSA's website to promote 988. And it's an incredible array of resources. And I also wanted to mention that when the 988 team was fortunate enough to be honored at Nationals Park toward the end of the baseball season, I was able to wear my Crisis Jam shirt on the field for that. So let me quickly go over just a couple of key things. We're all very excited because next Monday, our new permanent head of the 988 and crisis office will be starting, Monica Johnson from Georgia. So we are all looking forward to that. John Palmieri, of course, will be continuing to play an instrumental role, given the incredible work he's done over the last couple of years as the acting head to the office. And I think we may be going over some of this in terms of the report around from Congress, but let me just highlight a couple of things in terms of the appropriations and authorizations that were passed in December. So the 988 Lifeline received in the appropriations bill $500 million. So we were incredibly pleased with that, even though it was not the full 696 that was in the president's budget. But if you look at where we've come from, if you look at, I think it was 4 years ago, we were at 4 million to now be at 500 million is certainly a huge change. I would also call your attention to all of the authorizing language that now exists. I won't try to go over it, but for anybody interested in policy and advocacy, it's worthwhile going line by line. So there is now specific authorizing language for the office. The authorization for the Lifeline, which previously was pretty sparse. It was about a paragraph, and we were glad when it was first authorized because it had existed for over a decade without any authorization. There's now 9 pages of text regarding the Lifeline. So that's important to be aware of if you want to know about future directions now that Congress has put that into statute. The other thing that I'll mention that is specific to crisis services as well is that the community crisis partnership grants, you may recall we did 10 mobile crisis grants. These are grants that focus on expanding mobile crisis teams and enhancing the coordination with the 988 call center, with the 911 PSAPs, with law enforcement, with EMS, et cetera. The size of that got doubled from 10 million to 20 million, and authorizing language was put into statute for that program for the first time. So, it's really good to go line by line through these to get an understanding of the implication. I'll just give you one quick one. So the Garrett Lee Smith Memorial Act was reauthorized. One change that might not, get a lot of attention at first is that the age range for youth, and again, this is the program that has the most evidence for effectiveness in saving young lives, had a age range by statute of 10 to 24. That floor of age 10 was taken away, now says up to 24. What that means is that what's sometimes referred to as upstream suicide prevention would be easier to do, to be able to do some early work to try to prevent kids from being suicidal in the first place. So I will stop there. Thank you for the opportunity to share.
That is great news, Richard. Thank you so much for clarifying that piece that we would have never known without you really letting us know about that very important aspect. I'm going to move now to Arlene Stevenson to talk from NASHPID about parity.
Thank you, Megan. I'm here today to tell you about a new resource opportunity from NASHPID. It's called a Behavioral Health Parity Playbook, Strengthening State Laws and Partnerships. And parity basically is equity. That's the simple way to put it. It's between how a health plan or an insurer handles their services and their provider reimbursement for those services, as well as the cost sharing for the individual, things like co-payments and deductibles. So it's not uncommon that the physical health services are better reimbursed than are the behavioral health services. And so that's something we've been focusing on because of the sustainability issues for the crisis system. Inequity is illegal. There have been federal laws in place for more than 20 years. There are probably 5 or 6 different federal laws related to it. It's interesting to me that the issue of parity sort of started with John F. Kennedy. When he was the president, he required that the federal employees' health plan incorporate mental health services. So I just think that's very interesting. The playbook covers federal laws that support parity, and believe me, it's in layman's terms. I was not a lawyer, so this was a little intimidating for me. There is a description of the different parity approaches that are being taken by 4 states. It also looks at what the requirements are for Medicaid and CHIP for the state agencies. We're providing information on what criteria you need to use for assessing parity compliance. Also, the actions that states have taken against insurers. That's probably my favorite part. And also, there is a list of items that the Department of Labor looks for when they're conducting an analysis for enforcement purposes, and also what the most common violations that they find are.
And Arlene, I just let you know, Victoria has put a link to that publication that in the chat box. So please, everybody access that, just newly posted. And Arlene did amazing work on this as well.
Oh, thanks. I was just going to say too that the roles of the state behavioral health authorities in enforcement, we have 10 examples of that. We talk about the agency partnerships that I mentioned in our previous segment. And we have links to the model parity bills that the Kennedy Forum and the American Psychiatric Association have designed to assist states. And we also look at best practices for parity compliant processes. You don't need to be afraid. Like I said, it's in layman's terms. It's full of examples. It has a lot of links to resources. And we have 2 related resources that are coming up. These were not developed by NASHBA, but they are directly related. The first is an issue brief on behavioral health crisis services governed by the No Surprises Act and the federal parity law. And the other one is a crisis care parity action plan for states and providers. And that was funded by the Sozo Foundation. And I also
Arlene, thank you so much. I'm so sorry. We just have 3 more items and we have 2 minutes. So got to run. But Arlene, thank you very much for all your work and your dedication to this issue.
You're welcome.
We're not going to move it. Thank you. We're now going to move it to a federal update from Sarah Corcoran and Joanna Rosen.
Hi, everyone. We'll keep it very quick. Just wanted to draw everyone's attention to some of the FY23 funding wins that we saw heading into the new year. I think you can go to the next slide if you'd like. You can see the funding breakdown that we have here, and I know we're running out of time, so I'll just draw your attention to the fact that SAMHSA was funded at $7.5 billion, which is a $970 million increase over FY22 levels. And then obviously that includes the $502 million for 988 behavioral health crisis services, which does include a $7 million for the 988 coordinating office, which I know Dr. McKeon had mentioned before. So just wanted to highlight those, and we can skip the rest of the appropriations for now.
Thank you, Joanna. And Sarah, did you want to?
I'll just say very quickly, thank you, Megan, that we've got some CMS updates that we can share more about next week. But besides all of the wonderful SAMHSA appropriations and authorizing items, we do have some updates in the Medicare, Medicaid space that we can talk more about next week since we are running low on time.
Wonderful. Thank you so much. And then I just want to move to state updates from Jordan Pantalone from Vibrant, bringing him on again, and Hannah Kozlowski from NAMI.
Thanks, Megan. We'll try to run through this very quickly. So had 2 bills introduced in the past week that include 988 fees. So the first in North Dakota, SB 2149, that was introduced over the weekend. That would create a fee of up to 30 cents. And the second bill, Oregon House Bill 2757, that would establish a 50-cent fee. Both of those bills are primarily based around the NASH model legislation. Also, I'll just run through these all very quickly. Indiana SB1 appropriates $15 million in the next 2 fiscal years for crisis response and CCBHCs. Wyoming House Bill 65 would set up a 988 trust fund, and there's $46 million included in that. That was introduced just a few weeks ago. And in December, we had New Jersey Bill S3391, which would add postpartum depression services to the state's behavioral health crisis system. Sorry, that was really quick, but that is all, Megan. Thanks.
Great, thank you. And Hannah?
Yeah, Jordan hit most of them, but I'll just note that there are a few other bills that would appropriate funds. Maryland SB 003 would appropriate $12 million for their trust fund. Missouri HB 3010 would appropriate $1 million for marketing and promotion. And Virginia just released a bill, HB 2216, that would address insurance coverage at large for behavioral health care, but specifically also mentions mobile crisis response and stabilization, and lots of things coming from Illinois and Washington as well that would improve upon their previous legislation.
Thank you so much. Really appreciate it. Let me see, for the next episode, we have John Brogdon, who is, as I'm understanding, he's like the Nancy Pelosi, Kevin McCarthy kind of person in Australia, and is now the chair of Australia's Lifeline International because of past mental health pieces that he did that now fully he understands and advocates for. So we are thrilled in the next episode to have him. And then after that, Megan Jones-Bell from Google, February 1st. And thank you everybody for joining. Everybody have a great rest of your week. Thanks a lot. Bye-bye.